Thank you so much. So in this presentation, it will be connected somehow to the previous presentation because we are talking about the possible heterogeneity and stratification of depression. And the focus is on anhedonia. Why anhedonia? Because anhedonia actually has been described originally more than 1 year ago as an independent disorder. But in the following years, it has always been included since the DSM-3, so the 1980, included in the diagnosis of major depressive disorder, just as a symptom. But probably it's not like that, because recently there have been a lot of studies, converging evidence, suggesting that again should be considered somehow independent and therefore a very useful stratification factor. A very useful stratification factor that also is reflected by the interest in the research. You can see in the recent year there's been a very huge increase in the publication on the topic of anhedonia. Therefore, there is much interest. But for the ones of you that maybe are not clinician or not on the field, just one slide to describe what is anhedonia. Anhedonia is a markedly diminished interest or pleasure in all or almost all activities. This is the symptom as generally described. So the first take-home message of today is that this symptom is indeed common to many psychiatric disorders. So it's not only in depression. We can see in schizophrenia, substance dependency and abuse, PTSD, anxiety, eating disorder, and so on. So this is the first message that anhedonia is something that is really trans-diagnostic. Not only, to add another layer of complexity, anhedonia itself is not just one thing. For example, it can be divided it can be divided into two: anticipatory anhedonia, that is, I don't desire things, and consumatory anhedonia, that is, I don't feel pleasure when I do things that should be interesting for me. So at least two traits. Then another layer of complexity is that anhedonia is not always stable. So it's a state or a trait. It can improve, it can worsen during treatment and during time. Given all these complexities, anhedonia has been studied with different instruments, like the historical SHAPS and TAPS, but new ones, like the DARS, have been included because they include more dimension of anhedonia, not just anhedonia as a continuum, but the different phases of anhedonia. And therefore is much more useful. So in this part of the presentation, we learned that anhedonia is partially independent from depression, is present also in other disturbances. It's not a unitary construct. It is divided at least in two, and it can change a little bit over time. But just a couple of slides. What is anhedonia coming from? What are the causes of anhedonia? Well, of course, as many things in psychiatry, we are starting to understand now which are they. Indeed, a lot of structures are involved in anhedonia at different levels. That can basically be divided in two, that are the frontal ones, like the orbitofrontal cortex or ventromedial prefrontal cortex, that are the top part of the brain, the thinking, conscious part. And then there are the bottom part of the brain, hippocampus, hypothalamus, that are the ones that generate interest. So you can imagine a kind of interplay between what you feel that is dictated by the deep brain and how do you react to this feeling that is the frontal cortex, just to make it a little bit more, very simple. Even though there are a lot of studies on that, there are famous studies by Pizzagalli that are really wonderful. So a lot of structures that are playing into defining and causing anhedonia. And we are starting also to understand it from a genetic perspective, because in the latest genome-wide study, indeed, there are very interesting results, because we can explain from a genetic point of view at least 5.6% of the variants. That means that we are getting close to understand the biologic basis of anhedonia. And the 11 loci are very interesting because they are a mix of the usual suspects like dopamine D2, that of course dopamine is important in anhedonia, but also neuroplasticity and other structures that are somehow common with the other disorder. So again, another proof that anhedonia is something that is partially independent from depression itself. It is some kind of trans-diagnostic construct. Said that, Why anhedonia is important? Because you could say, okay, it's independent, it's a symptom, it has a specific pathophysiology, then what? Then what? The problem is that anhedonia is very detrimental. This is a very recent paper that we published this year, but there are many of them. The point is that if our patients have anhedonia, it is a marker of much worse outcome. Negative prognostic value in any direction, more severe and more recurrent depression, in this case is depression, higher number of previous depressive episodes, longer depressive episodes, greater overall disease severity, persistence of residual symptom after depression. So indeed, this is something that is not immediately understandable by us, by clinicians, because we are used to think, well, patient has depression, obviously as anhedonia. No, because at least in my personal experience, but I think in everybody's personal experience, I can remember many patients that indeed, I remember specifically two that had anhedonia without depression, anhedonia only. It was difficult for them to understand because there were no other symptoms of depression, just anhedonia. So before there was depression, depression remitted and remained only anhedonia. And these are quite difficult to treat. At the opposite, I can remember, they are in the data, but also in my personal experience, as in yours, some patients that have depression without a very strong anhedonia. So it is possible to have a heterogeneity within depression based on anhedonia stratification. Okay, so we understood that anhedonia is independent, transdiagnostic, important, detrimental. Okay, let's go to the treatment. The treatment is not so simple because, of course, the first treatment that we have in mind is antidepressants. Not so simple because if you think what antidepressants indeed do, this is one of our old papers, but there are all the papers by Catherine Harmer here, that antidepressant, SSRI in particular, can lead to a blunted affective consequence. Therefore, it can somehow worsen anhedonia in some patients. So we are in a tricky situation because we have to treat depression that sometimes have anhedonia or very high anhedonia with some drugs that can be detrimental on anhedonia itself. So it's not the first choice when you have a patient with depression and anhedonia and then go with SSRI, sertraline, paroxetine, and so on. Probably not because of this effect. Then what? Then, in this review of 2 years ago, I tried to make a ranking of what we could use in patients with anhedonia. And there are a lot of substances with good evidence about what we can do. For example, agomelatine. Agomelatine, we are not, I don't know the use in your countries, but at least in my country, agomelatine is not extremely used. But for a subset of patients where there is a predominant anhedonia and maybe sleep disturbances, agomelatine could be a good choice. Vortioxetine as well. Ketamine, of course, and esketamine are effective. And transcranial magnetic stimulation, we will see in the next slide something about that. Emerging treatment, like psilocybin, still experimental, but they are very promising. Bupropion, alone or with dextromethorphan. You know that this new combination of bupropion, dextromethorphan is extremely interesting and extremely promising. Some SSRI, venlafaxine, methylphenidate, CBT, and pramipexole. So the question that I think that you all have in mind now is, okay, nice. Which of these one should we use then? It depends on the patient. So you can have a patient with anhedonia and sleep problems. Well, the choice is more on agomelatine rather than bupropion. Obviously, you can have the opposite. You can have a patient with depression and hypersomnia. Then, of course, the choice is much more on bupropion. You could have some patient with predominant obsessive trait symptoms. And in these cases, anhedonia, depression with some obsessive trait symptoms could indeed suggest the use of SSRI, because in those patients, SSRI would reduce the top-down component of anhedonia. So this is just a brief discussion about how to choose within all the possible treatment that we have for anhedonia. But 2 years later, I realized that now, this paper has been published just now, a few months ago, I realized that indeed the field is moving very quickly. And my review of 2 years ago, it was already old. So I did another one. And I tried to cover a wider perspective. So, okay, the drugs that I told you before are still there, of course, but a lot of new information came from the neuromodulation part, not only the usual TMS. There is the high frequency TMS, the direct current treatment, the transauricular vagus nervous stimulation that is very promising. And probably the most interesting is the connectivity guided protocols for personalization, where you decide exactly where to apply the magnetic stimulation. So this neuromodulation part is extremely promising in terms of treating anhedonia. And also in terms of the psychotherapy techniques, other than the usual cognitive behavioral one, many others have recently appeared. And of course, the accent on the lifestyle aspects you heard from the previous presentation, immunometabolic components are important. They can also lead to anhedonia. And therefore, if we work also on that with aerobic exercise, diet, and so on, to lower the, have you seen C-reactive protein and so on, this is another converging evidence. This is why I put the four around anhedonia, because we should not rely only on drugs. It should be a combination of treatment to anhedonia. To anhedonia, to the patients that have prominent anhedonia, stratification of MDD, of course, but also other disorders. More in detail, you can find this paper is open access, so you can easily find in the web. More in detail, you can see which is the strength of the support for any of these treatment. Probably the most supported one is ketamine, and there's ketamine, of course, because it is really effective. The point with ketamine and esketamine is the maintenance, how long should I go on, and this is another topic for discussion. The stimulation methods are really promising, as well as vortioxetine, because vortioxetine, you know, a multimodal antidepressant that is probably the one that is less giving the affective detachment compared to other SSRIs. So it is interesting for anhedonia. Agomelatine, I already told you, bupropion, more or less combined with dextromethorphan. For some patients, trazodone, but I would be a little bit careful at the point of using trazodone in anhedonia, unless maybe they are a little bit anxious or with insomnia and so on. But much more interesting is the combination, as I told you, dextromethorphan and bupropion. And there is one indication for lumateperone. Lumateperone, however, is an antipsychotic, so it could be indicated in the area of schizoaffective disorder, not for all of them. And then there is the interesting story of aticaprant that is targeting the opioid receptor. This is very interesting. There were very nice results, not very clear results afterward, but probably here is a typical case of stratification. Because we've seen the orthogonal axis where anhedonia is present across various diagnoses and anhedonia itself is divided in many aspects. So the combination of the specific patients that can benefit from any of this treatment is quite difficult to identify. Psilocybin would be wonderful if and when we will have it in clinical practice. So I want to conclude this presentation, and I would like you to remind some take-home message. We are talking today about the stratification of MDD. MDD is indeed heterogeneous. This is always our experience. There are so many vectors of heterogeneity. It's so difficult to stratify well depression. Anhedonia is probably a very good way of stratification because it is a variable within depression. It is partially independent in terms of physiopathology and genetics. And it is also detrimental. Patients with anhedonia have a worse outcome. So anhedonia is important. Anhedonia is important also for the treatment because when you have to choose the treatment for depression, remember you have more than 40 antidepressants, so it is already difficult. But consider when you go home and you see patients with anhedonia, okay, what I heard to the meeting is that probably if there is a predominant anhedonia, I should use one of these drugs that were listed in the slides that probably will target better anhedonia and therefore improve better depression for a long-term outcome. And it would be wonderful in the future if we could use a personalized treatment based on biomarkers and genetics and all these wonderful things that we are still studying, but this is probably for one of the next ECMP meetings. Thank you for your attention. Exactly. I appreciate that the audience is grasping the complexity that is behind of what we see every day in our hospitals and outpatients unit. Apathy is something that is mainly linked to energy. Apathy is somehow, I remember some patients with apathy without anhedonia because they still have the desire of do things, but maybe they don't have the physical energy to do it. So it is a partial aspect. And burnout or PTSD is a reaction on an event that happened. So again, is another dimension. But this question is very useful to understand that when you see a patient that looks somehow not active, let's say, then we have to dig and understand exactly if the basic mechanism is an hedonic mechanism, an apathic mechanism, or a reactive mechanism, because the intervention is different. Ah, this is a very clever point. Thank you. And this, if you think carefully, links to the slide when I showed you the circuitry of anhedonia. The different mechanism of action of drugs that treat anhedonia reflect the complexity of mechanisms that cause anhedonia. So you can either act directly on dopamine with bupropion, and that is part of the mechanism. And therefore, you can start the chain of events that release anhedonias. With ketamine or esketamine, you target the plasticity. So even if the, let's say, the stimulus is not so strong, but you, with esketamine and ketamine, improve the plasticity of the system, therefore the patient improves. So each of them is targeting to a different step of the cascade of events that lead to anhedonia.